Of course, music, I would say, helps, especially Bach. You know, I can't, by the way, operate under the Mozart music. You know, it's impossible.
Or Shostakovich.
Or Shostakovich, or Beethoven. You know, but Bach, that's fantastic. You know, maybe Haydn, maybe. Who else? No, only Bach. You know. It's relaxing, you know, and starting to concentrate and not rush and not some bad emotional things, you know.
Well, good evening, everybody. Thank you very much for coming again to Gresham College. I've had a huge privilege doing these talks because I get to talk about my job and about what I do, which is something that not everybody gets the chance to do. And one of the most common questions I've been asked afterwards by members of the audience, by people like you, is what does it feel like to hold the baby's heart in your hands when you're operating? The baby's heart, newborn baby, is the size of a walnut, not very large, and the components inside it are even smaller. I thought it would be interesting not just for me to tell you what it feels like, but to ask my colleagues around the world. So they were very kind, gave me a lot of their time, a lot of their energy, and I have interviewed them on video, and I'm going to have a very lazy evening myself tonight and be able to show you what their views are about holding a baby's heart, but also about aspects of their life that I hope will paint a picture of what it is to be a cardiac surgeon and about the pressures on them and about how they feel about things in general. Actually, they were surprised to be asked these questions. I think for most of them it was the first time they'd ever been asked what they felt about anything, which was eye-opening in itself. And I've been completely dependent on their openness and their honesty and their willingness to give of their time. I've been really pleased to see how dedicated and humane they are, and I hope some of the words that you're going to hear will exemplify that. Let's start with some words from Professor Jeff Jacobs, who works at Johns Hopkins University in Florida.
Everybody wants to have meaning in their life and make a contribution, and there's perhaps no better way to wake up in the morning, look at yourself in the mirror while you're brushing your teeth and think, today, if things go well, I'm going to help somebody, I'm going to help a family, I'm going to make a difference. And it's going to require every ounce of energy, every ounce of intellectual ability, every skill I have. But if I do it well, it's going to make a difference, it's going to help somebody, it's going to maybe make it that somebody can live. And the ability to make a difference like that, that's why we do what we do.
When we are setting out to operate on a child's heart, it's not self-evidently risky, inherently risky, and any mistake that we make could have lifelong consequences for the child and for the child's family. The margins are really small, and in a newborn heart, as I said, it really is the size of a walnut, and the insides are even smaller. Those components mean that one slip can be fatal. It's very difficult to give lay people an impression of what that's like, but I think Professor Luca Vricella from Johns Hopkins in Baltimore gives us some idea of what we feel as surgeons.
So if I have to describe the feeling of operating on a newborn heart, I think the perfect analogy is that of driving a car at 200 miles an hour on a single lane with water on either side. There's no room for error. And I think it's the most exhilarating yet humbling experience that you can possibly have. So to just, summarize it, I think that it's, pediatric heart surgery is a perfect balance between courage and fear.
Well, it certainly makes you feel fearful. I'm not sure that courageous is the right word. Sometimes you have to be. But what does underlie all this is another emotional layer where we have to form and do form and enjoy forming relationships with our patients over a long period of time. Those relationships are crucial, I think, to enjoying your job.
And you have to be willing to have a long-term relationship with these children. It's not in the operating room. As I say to parents, you know, our relationship is not limited to this day in the operating room. You don't want to see me, but I want to see that postcard at Christmas.
That postcard at Christmas means so much, just to know that someone's doing well over time. It is truly a privilege to be allowed to do this job. Most of us got into it just by working hard and almost by mistake. But once you're in it, it is an enormous privilege. And I found these words from Christian Kreutzer, who is Professor of Pediatric Cardiac Surgery in Buenos Aires, really interesting to try and get over how not only do you feel about the patient, but what it makes you feel about your job.
Maybe we cannot save this child, but at least we should give the child all the love that we have and the family all the love that we have. And if we're not able, well, this at least will be the way that we will grieve best. Just knowing that we did the best that we can. Find a job that you love and you don't have to work anymore.
Wouldn't it be nice if it was always like that? Before the surgery starts, we as surgeons have to encounter the patient in some way. They're referred to us either individually or more commonly via a cardiologist. And then we have to debate what to do as we get to know the patient and the condition in more detail. And most of that planning nowadays takes place in a multidisciplinary meeting where we sit with the surgeons, the cardiologists, the anaesthetists, the nurses, the intensivists, in a room, watching the data presented electronically so that we can make rational, protocol-based, technical decisions about what the right thing to do is for the particular diagnosis that this child has. Those MDTs, multidisciplinary team meetings, also have to address important ethical issues with the treatment of a particular child, asking, is it right to do this, or would it be better not to? And we have to take into account logistic problems, medical, social, capacity, and increasingly financial constraints, which have to work out how we prioritize individual cases one to the other. And that takes up probably a disproportionate amount of our time because we're so capacity limited. Now, when I started to be a cardiac surgeon in the 1970s, I really found it incredibly important to have a very close and strong relationship with the child and the family that I was about to care for. The busier you get, the harder that becomes. And the more technical and complex and challenging and life-threatening the operation is, the more the risk of an emotional engagement. I thought it would be interesting to ask whether or not knowing the child in advance of an operation was a help or a hindrance to cardiac surgeons in the modern era, because you could care almost too much.
I like to see the child before surgery. I like to have an image of that child in my mind, but I try not to have too strong an emotional link, because I think my job at that very moment would be to deliver the highest quality of surgery to get the child through the operation.
And Victor feels that he can't do that if he's too emotionally engaged.
I don't like to see too much the patient before a procedure. I see and talk long with parents to explain what's going on, what are the risks and the outcome, expected outcome. But I try to keep a distance, at least for the first procedure, with the baby or the children, probably in order to not to put too much emotion in the engagement that we have, and to make it more technical.
making it more technical, bringing it down to the basics of what you want to do.
And if you think about the way that our drapes are in the theatre, they're all opaque. Okay, and that's, yes, they're all sterile and it helps our eyes adjust to the field of interest, but probably there's an element, they're opaque for a reason, because in order to process it yourself, you have to come to work every day and do the same thing every time. I've got two young children at home, and to a large extent you do depersonalize it.
So these people are feeling that they need to separate themselves from that individual child in some way to be able to perform as well as possible. But to deny the presence of emotion, I think, is wrong. And this is probably best expressed by Professor Bogdan Maraszewski from Warsaw.
A lot of sensitivities, a lot of emotions. We are all very emotional. We are all, even if we cover it, if we don't show it, inside ourselves we are very emotional. A lot of responsibility for patients.
You're going to hear that word responsibility a lot more this evening. And getting ready now, having discovered what's wrong with the child, having made some decisions, having met them, being ready to do what it was you planned to do on the particular day, you need to get yourself mentally ready. And most cardiac surgeons will start that maybe the day before the individual operation, check everything through, sitting in their office, working through. Some will even write down plans A, B, C, and D if various things occur, planning for the worst as well as for the best. Others, like my mentor, used to arrive at 4:30, 5 o'clock in the morning and pace the corridors, getting increasingly pale and anxious until the time of the operation, when he would then relax into his skill base. I like, when I'm cycling to work, I'm going through each step of the operation in my mind before I hit the taxi. Once you've got these plans in your head, then they're of zero value if you're not sharing them. The plans have to be shared with the rest of the team, and communication is a crucial element of this. We, as you'll see in a moment, brief very carefully amongst ourselves in order to do this, and spend a lot of time cross-checking that it's the right patient having the right operation in the right place on the right day, and we've got all the right equipment. That is crucially important. You would not want to have the wrong leg taken off. So the briefing takes place with all of the staff in the anaesthetic room of each operating theatre at the beginning of the day, when all of the patients that day are discussed. Every detail of what you need is checked. Everybody introduces themselves by first name, and most importantly, the details of that particular case are discussed. But we also encourage everybody to speak up. This is their opportunity to feel part of the team. When the child has been anaesthetized and brought into the operating room, everything is rechecked again. You see the consent form is being checked against the name band, and everybody is identifying themselves once more. A further check. While everything is being prepared, we can redraw a line on the patient in exactly the right place for the incision, make sure it's nice and straight. And then prepare and drape the skin by painting it with iodine, and as one of my colleagues said, and making it look like a Caravaggio by making everything go dark around the outside. Patient is then draped by adhesive drapes, whilst the surgeon is getting ready in the corner, finishing off that last mental preparation whilst washing his or her hands. And I did mention that the heart was the size of a walnut, and as you'll see from Nagarajan's head, he's wearing glasses like these ones, which magnify 4.5 times and allow you to operate carefully on a very small heart. So we cheat and make the heart bigger. He's also got a camera on his head and a light, and these have become much lighter over recent years, but used to weigh up to 6 kilos. And this is a long piece of hard work to wear for 7 or 8 hours. Now you're ready for the incision, to make a cut in a baby's chest. And I remember the first time I did it. I remember what it felt like and how scared I was. But I think there's something more to it, because this has to extend over not just the incision, but the whole operation. So I asked people what they thought about this process of making an incision in a child.
I think you have to be very confident. I think it would be impossible to go into the operating room with a feeling that I can't do this. You have to go in with the feeling that I can solve this problem. Even if you have some idea that it might be difficult to do, then you have to have this self-confidence that you can do it.
That incision is cutting into a child, and it's very scary if you're not used to it. It takes you to another level that you have to feel you can finish the operation.
And that confidence doesn't come out of a Christmas cracker. It comes out of years and years and years of practice over and over and over again.
Mike's absolutely right. You don't get that confidence without the practice. And so the whole training process involves doing a little bit more of each operation as you get older and older. Now, the moment that you first see the heart, especially when you first start, is really exciting. And we're getting close to the time now where I can ask that cool question, what does it feel like to hold the heart? Now we're just getting our first look at it. And when you do see the heart appear, it's behind the pericardium, which is a membrane that the heart sits in, and there it is, the heart beating in the chest. An astonishing sight. And this is where I asked all my surgical colleagues what it felt like to hold a baby's heart in your hands. All that life in your hands.
Well, I do try to understand the strength of the heart. Not only it is a beautiful pump, but it is so soft. At the same time, it is so strong. And in the vast majority of the patients, the heart is very kind.
I'm not sure what Confucian's statement, Victor, means by that, but you get this sense of something bigger than just a pump or an organ or a job.
Holding the heart of a little baby in one's hands is the most powerful responsibility that exists. And as you hold that heart in your hand, you think, well, the life of this baby is in my hands and in the hands of our team. I think we remember that this is perhaps the biggest responsibility an individual can have.
We all love our children, and it's a huge, huge responsibility on your shoulders to have somebody's children's heart, kid's heart in your hand. And however, as big as this responsibility is the pleasure and is the joy of repairing a heart and seeing the light in parents' eyes, that is a huge, huge pleasure.
It really is a huge pleasure.
I think there was another time when it was very significant. It's the first time I operated on a newborn baby for a complex operation. And this time I really realized how mad you have to be to do this on a small baby. But it was just as small as this. So for a very technical operation, you're very focused on the technicalities, but at some stage you realize that you have a little baby in your hand, and it becomes very scary.
Very scary as well.
And there is a physical part, touch the heart. In this moment, I think the emotional part is less, but sometimes arrive to me in my mind to think about the history that I said to the parents in this moment. Normally, I try to avoid that, but to be as cold as possible. But human being not always arrive to do that.
Lorenzo, I think, makes a really good point. No matter how hard you try to separate yourself from the emotion, it breaks through. whenever you're doing this kind of work, because you know that child, you know that family, and you want to separate yourself to do a great technical job, but it keeps creeping into your life.
Well, thinking that with your hands, with that little heart on your tip of your fingers, you're able to recreate anatomy or to transform physiology. So basically at the moment, sometimes it's scaring. Afterwards it gives you pleasure, and before it gives you worry.
Well, the first times when you were assisting as a young surgeon, it was very magical because you were kind of a spectator. You were experiencing something for the first time. When you stand there as a surgeon yourself with the responsibility, I think it's a very different experience. Mainly, I think of this as I experience this as a mechanical thing. I work on a machine. I try not to think too much about the fact that this is a baby with parents and a lot of emotions around it. I try to isolate myself from that because I think it's difficult to do a good job if you are thinking that I cannot afford to fail. It's better if you are detached, actually.
I think it's necessary to differentiate between the job and this emotional background.
I don't actually feel anything. So I think sort of metaphorically, I think the way I choose to answer your question is to be responsible for someone, for someone's being. But I think it can be a distraction to actually think about it whilst you're doing something.
The feeling changes, obviously, because as a registrar or as a trainee, sure, you're opening, you got a heart in front of you, you're holding it, but ultimately you're not responsible for whatever happens. But I do remember, the first few cases that having the heart in front of me, and I am it. Having lost, have no parachute, have no more protection, and that whatever happens with that heart is on me. And I remember the gravity of, so all of a sudden you hit with that gravity.
I would say generally I try not to hold the heart and try to be very gentle, and I think that's pretty deliberate, and I think that to a great extent I learned through a surgical school where you try to deal with the heart through the end of your instrument. So the instrument is the end of is a prolongation of your, finger, so to speak. And there is the emotional component, which I think for me is mostly about the tremendous responsibility and the accountability that you are held,
But I think it is fair to say that most of the time, certainly now and for years, when manipulating or operating on a baby's heart, you don't feel anything. Because I think we are trained not to feel anything, because we focus on what is necessary to do.
The word that kept appearing through those descriptions of what it felt like to hold the baby's heart wasn't something profound, except for Victor's Confucian statement, but more for this sense of responsibility that seems to be huge and immediate and ever-present for all of them. And I thought most movingly of these interviews and most agonizingly honest is this from Antonio Corno, who now works in Leicester but has worked all over the world, and reflects some of the tensions that this battle between technique and the technical side of surgery and the emotion of it.
At the beginning, when I was very young, so long time ago, I couldn't separate the technicalities of the operation from the fact that I knew the child and the family. And this was a total disaster because my emotional feelings were giving a lot of problem to me when things were doing not following the expectation. And after one or two cases where the child was very, very sick, after the operation, I decided that that was not the way to work as a pediatric cardiac surgeon. I had to learn to completely separate the technicalities of the congenital defect requiring a repair from the fact then the heart was the heart of the little James or Hannah or whatever you want to call it. And it took some time, but this is what saved me. Otherwise, I would have stopped doing this.
He had to learn to separate those two things, which clearly for some of the people we've interviewed came naturally. But if you are a sensitive soul, then it can be very emotionally charged throughout your career. Now, we've now seen the heart, we've touched it for the first time. Now we want to get on and fix it. And you have to prepare the child for going onto the heart-lung machine. And that means sticking some pipes into the circulation. And the most important pipe to stick into the circulation is the cannula into the aorta, which returns blood to the circulation. And there is the aorta in the middle. That's carrying all the cardiac output, 4.5 liters of blood, and you have to stab it with a knife. And then place a little cannula in there. And I thought it would be interesting to ask the surgeons what they thought, because it was a very terrifying moment for me when I had to do that, and I wondered what it had been like for them.
Yeah, well, it's quite scary. I remember the first time I had to cannulate, but that was an adult patient. First time as a resident putting an aortic cannula in. I was scared stiff, and then I made a hole, put the cannula in, but too late, so I was covered in blood. That was my first experience with aortic cannulation, yeah.
I remember the first time, and I was really emotionated, and I passed very close to put the knife into my hand instead of the heart.
I wouldn't say it makes me nervous. It's certainly a step of the operation that we do so often, even though I do it every day, but that's one step where I typically just take a little deep breath before I do it. You know, you slow down a little bit, you know.
Because you remember that first time, and you want to be in control of the knife and the beating heart. Now, assuming that you don't stab anything and get covered in blood and don't ruin your hand, you can move to the next stage, which is stopping the heart. Because if you're going to want to operate on the inside of it, you can't do it with blood flowing through it, because it'll just suck air into the circulation, and you can't really do the inside of a tiny heart if it's moving about too much. So we stop the heart to allow us to look on the inside. And this is done by using stuff called cardioplegia, which is a high potassium cold solution at 4 degrees centigrade, which is mixed with blood. You put a clamp on the aorta, which you can see here, between the cannula which is supplying the body and this little pipe, which is below the cannula and flushes cold blood and cardioplegia solution into the coronary artery. And as this flows in, the heart slows down, cools down, and then stops. And then once it stops, you can keep it cool by adding ice to it, and every 20 minutes or so, you can repeat it so that the heart can be continued. The heart surgery can be continued for a little bit longer. Once the heart is stopped, you can then open it, because you're not going to suck air into the heart, and you can repair the inside of the heart. This is a slightly bigger person having a very simple operation. But the stitches are being placed, and once these are placed, the operation is over. But it's time limited. Even though you can give cardioplegia over and over again, and even though the heart is at 4 or 12 degrees centigrade, it's still metabolizing. It's still using up its stores. And gradually, over time, its function will deteriorate if you leave it like that. And so, unlike most forms of surgery, you have a very time-limited episode in which you can do this job. And that adds yet another layer of stress to the surgeon doing the work, and requires a particular type of brain. So when you release this clamp, take that clamp off the aorta at the end of the operation. Blood, warm blood, flows down the coronary arteries, flushes out that cardioplegia. In a very short time, the heart starts to beat. There's the clamp coming off, and in just a few seconds, the heart begins to beat, and you can finish off closing the heart. Here you can see now the heart beating. That's just 8 seconds later. And this is quite a remarkable moment when you think about it. And the surgeons have some interesting views about what it feels like when that clamp comes off and the heart's beating.
When a heart sits in the chest not beating while we repair it, and then all of a sudden when we're done with the repair, we give blood to the heart and it starts to beat, that is a very powerful, exciting, and awesome moment.
Every time the heart starts beating, and especially when I look to the EKG and I see a normal EKG, that's good. And it, gives me joy, and then I think, well, again, a case that was solved.
One would be the moment of joy that it is the completion of a very difficult operation. On the other hand, it can be a moment of uncertainty because the repair may not work, the heart may not work well right away, or the rhythm of the heart may not be coordinated. So it is a bit of a mixed emotion.
You take the clamp off and when you see the heart beating again, it is just a miracle to me.
To me, there's nothing more powerful, there's nothing more reassuring than when you see that heart start vigorously. You know that you're going to be okay.
And it's always a very stressful or challenging situation until when you see the heart beating with the rate you want, the color you want, and you feel completely relieved and.
So for me, once his heart starts to beat and have a rhythm, I don't get a sense of achievement, but a sense of relief that, okay, I've escaped.
I love that sense of relief that you've worked all that time and this heart's going to go again. That's really powerful.
And that's the most enjoyable and even, I would say, could replace some food, I never felt that I'm hungry, during the operation. Never.
Just exciting.
That's exciting, that's right.
It's exciting as well. I think not only does it avoid you having to eat anything during the operation, which I'm sure is an advantage, but some of my colleagues find that they want to encourage the heart to beat.
Well, sometimes I speak with him. To the heart? I said, well, just start to work. That's your job. Exactly. What you said, that works. That it's amazing. After so many minutes being completely flat, the heart all of a sudden starts to work, and you see how nicely it's contracting and so on. This is extremely rewarding feeling after the operation because you have a feeling that, well, it's moving in the right direction.
On the other hand, some of them have felt rather than you need to encourage the heart is actually encouraging you.
I think it's actually my favorite part of the operation. And the baby's heart is speaking to you, telling you that you've done the operation correctly and you're actually going to get separated from the heart-lung bypass machine. I'm going to survive. I want you to know that, and then you make that all happen. So yeah, it's a good point in the operation.
It is a good point in the operation. But not all operations are easy or straightforward. The inside of a heart is really tiny. This is the inside of a child with a complex atrioventricular septal defect, 1.5 centimeters. There are over 3,500 things that you can have wrong with your heart when you're born. Lots of small ones that add up into bigger things. And 2,500 individual procedures in our coding system to describe those. As a paediatric cardiac surgeon, you're supposed to know those. It's not really surprising that trying to balance all of that with the emotional attachment that you've developed to a family, with the technical complexity, with the size that you're seeing, and this sense of overbearing responsibility, plus the fact that you're working with a lot of people, makes the potential for things to go pear-shaped real. And trying to retain your control under difficult conditions in an operating room is something that's always interested me. So I thought I'd ask the surgeons what, if they'd ever lost control in the operating room, and some of their stories make interesting hearing.
Yes, I think all of us who are in this job sometimes feel very helpless when things go terribly wrong. And sometimes you feel that there's something I should be able to do, but sometimes you can't. And it's a very bad feeling. It's because you want to. What I think, oh, how do I go and if something like that happens, how do I go and how do I explain it to the parents that there's nothing I could, that nothing more. I mean, I almost feel like that I can't tell them that, oh, there's nothing, that really is like a phrase then that, oh, there's nothing else we could do. Yeah. Because you feel like, well, there must have been something. Yeah.
Yeah. That feeling that there must have been something I could do. And Martin is one of the best technical surgeons in the world. And to see him not just struggling to explain it, but struggling for the words to make a sentence, a whole sentence up, to get through his frustration at those moments when he just felt he doesn't know enough for that particular child, I've found very moving.
Yeah, it happened. In many conditions, I had this situation that I was not driving, but I was running behind the situation. Your mistake is often in the decisional, because hand gestural mistakes are very rare, despite people are believing, very rare.
So Emery is saying it's a decisional mistake. Usually it's your choice of the various options. It's incredibly rare for there to be a technical mistake. These people are incredibly skilled, the best in their countries. And it's still this feeling, I love that expression of not driving but running behind. That's exactly what it feels like when you're losing control of a whole situation.
Oh yeah, that happens. It happens that things go worse or quite badly, or worse than you expected. I think it's always the moment when I think, how am I going to save this child? Not how to finish this operation the way the child survives.
So not being able to go ahead with your plan to do the technical repair, but finding a way of getting out of the operating room with a live child. Everything has to change when you're under such desperate circumstances. And you can see from Bogdan's body language how stressed he is even just remembering that. Now, I haven't got time to show you all the things that people have said about these stresses. In the handout that goes with this lecture, there is more detail and with more expansion. But I thought perhaps the lesson would be, how do you manage when it starts to go out of control? Because that doesn't just happen to surgeons, it happens to all of us. And how should you deal with that situation when you are beginning to lose control? The first one is not really dealing with it, but I just like what he says.
If I notice that I made one mistake, I obviously became very angry, and I said, how can I do this?
And do you get angry with others?
No, with myself.
Would people in the operating room be able to see you were angry?
Well, I try not to, and obviously I they say that I'm nice in the OR, but I'm the boss, so.
It's much easier to be nice when you're in charge.
I may be feeling out of control inside, but on the outside, I try to maintain a certain composure because it is very important at the time of crisis. There must be some leadership because everybody in the operating room is looking at the surgeon to direct them what to do next. But the feeling of your heart sinking slowly, slowly, slowly down to the level of your ankles can be very unpleasant.
Where you must not, this is a moment where you must not completely crumble to panic, and I think if you show everyone that you're in complete panic, then everybody panics, and then the whole team is unable to work. So I guess this is a moment where you need to slow down and appear more in control, even though you don't feel it.
Probably the best advice comes from Tom Carr.
There are many times when I felt out of control. It's usually a chain of events that happens, starting with one small thing that leads ultimately to some big and terrible thing. And there's a lot of room for error in a pediatric cardiac operation, and there are many people involved. I think what I could recommend about a moment like that is if you can't keep it together, neither can anyone else. And lashing out at the only people on the planet who can get you out of that situation at that moment is definitely the wrong strategy. And I think as surgeons, many of us have missed that in our life training.
Tom and I were residents together, registrars together at Great Ormond Street many, many moons ago. So we recognize similar tensions over our lives. In truth, the surgeon's only a tiny part of this work, and it really is much more common nowadays to think about what we do as being a member of a team. And I asked them how you felt about the team.
I totally agree with you. It's a team sport because any member of the team is contributing to the success of the procedure, and any member of the team can create a disaster in any moment.
So that you are not just the sole person in a team as the surgeon who is fundamentally accountable, but society, as we discussed in the blame lecture, often sees it that way.
Nevertheless, nowadays, not only in medicine, but also, let's say, Formula One, Ferrari, the same thing. Enzo Ferrari and was having great result, and at a certain stage it started to go down. Why? Because you need to work as a team. Teamwork, that's the name of the game. And you guys from United Kingdom taught us how to work as a team. And for us Italian, and any Italian wants to be the protagonist, that is the problem. So to work as a team is extremely difficult. Nevertheless, it's still possible. Teamwork is the name of the game of our results nowadays.
Teamwork, emotion, but the dominant word has been responsibility. And that responsibility and that workload take their toll. 30 years of being on call every day or every other night, called out of bed all the time, patients as sick as this, emotions running high, a team to support. These are stressors which are not only tough for the surgeons, but obviously for their family and friends. And I've been very surprised over the years how even my closest friends don't realize what it means to be on call. They don't really understand that you really do have to get up and go out of bed or leave a dinner party or something. And so I asked them, has the workload and responsibility affected your family life? And do other people get what you do?
I think that responsibility has affected me as a human being, as a family man. I think that more so than in probably most other specialties in surgery, we are what we do. And we're on call 24/7, 365 days a year. and we're always responsible for our patients. We always go in the middle of the night. You don't delegate, you do it.
It's difficult to speak about our job in society. You're having a nice dinner and somebody asks you, so what did you do today? Are you really going to say that you had someone who was dying and blood everywhere, or a disastrous situation, and that you had parents crying, and that yourself you were destroyed, and when you're supposed to just have a nice dinner and share glasses with some friends? So yes, people have trouble understanding it, and I think nobody can really imagine what it means to, unless you really do it. You know, the hospital world is hidden for most people, and it's a world apart. People have a lot of trouble imagining what goes on behind the walls of a hospital. So, yeah.
I think the work of the cardiac surgeon being so demanding will necessarily affect all your family. I would say that all the family will end up being part of the team, because necessarily you bring home all the worries. It's a permanent, full-time job. So, I mean, I think they will share my worries in the day before, the arriving home late in the day, and the joyness or the sadness if things do not go well.
You know, majority of your life, if you dare to operate on children's hearts, is to wait for the phone call from hospital. So the life of the congenital heart surgeon is a bit different to what we think should be a normal, regular life. Of course, that has an impact on the family. There's my wife next to me, who's experiencing all of that with me. I know she's a part of that. The whole home is part of my professional involvement. So it's not a single person thing. You really affect people around you.
And I think in the past I was told that I'm not able to focus on anything else but my job. So clearly the attention I give to my job is must be above what other people think I give to everything else.
Yes, I do think so. Of course, I think it's very hard for people around you to accept the same sacrifices that you impose on everyone, on yourself and on everyone in the end. And I think for the children, my 6-year-old daughter, once I was called during the holidays to operate, and she said, "But is there no one else? As it has to be you who go and operate?" She was quite angry. She's still angry now when I have to operate, when I'm supposed to be with her.
Out of my 5 children, 4 of them are physicians, are medical doctors. They complain about that. They could have their father, but they could not have the big amount of time they could have expected. You know, but when you are hungry, it's not enough to have a nice caviar sandwich. You need a big steak, you need a big dish, a big plate. You know?
I love that. Caviar sandwich is not enough, you need a bigger steak. But you know what he means.
I might have done a few things differently, perhaps, if I were to do it all over again. And those are things that relate perhaps to decisions about personal life and personal time, you know, children and things like that. I think that we all postpone or sacrifice tremendous amount of, you know, individual personal, you know, life considerations just because we're after this goal. And sort of it's only in retrospect that you realize, ooh, you know what, yeah, the goal, I attained that. I wish I would have, you know, taken a little bit of a different turn a little bit earlier in my life.
It takes you 24/7 because different from the post office job when you finish 5 o'clock. That's it. No, when you finish, the patient is still there, can be still sick, they can need your help, or you want to know how the patient is doing. So you are 24/7 in the job. And this is creating the major problem on the other side, which is the family life, because that's the place where I found the most important difficulties in my personal life, to combine the expectation of a job with the family life, and I cannot say I was successful.
Life could have sometimes been easier. Your commitment is so huge, and sometimes you wonder whether you could have spent more time with your family and give your own children a bit more instead of giving the other children.
It's been an amazing experience talking to these guys who really never talked about what they do before, much to my surprise. I hope I've shown you tonight a little bit about what their lives are, about what they do, and about how they feel about things. They're a little bit more than just what does it feel like to hold a baby's heart in your hand. I was struck, and I hope you've been struck, by their evident dedication, a deep sense of responsibility, a commitment to children, and a love of work which left their mark on me, certainly. There wasn't any talk, apart from at the end when I asked them about the hours they worked or how much they earned. And they all clearly want to do their job to the very best of their ability and make these children better. They know they must be available 24/7, 365 days of the year, and they recognize the pressure on their family. I thought I'd ask them whether they would do it again, given those pressures. And this is what they said.
I think I will do it again. Yeah.
I will still go. Absolutely.
Oh yes, I would do it. I would do it.
Nothing else. I would do the same thing.
Absolutely.
No, I think I do the same.
I would say yes, because I'm doing what I have wanted to do in my life. I'm a lucky people.
This is a perfect job.
Yes. Oh, I love it.
I think it's fantastic if you see all the little photographs on the wall of the little squirts that are now bigger kids, or you see them in clinic. I think that's a great satisfaction. I would do it again for sure.
And if I would have a chance to go back, I would do exactly the same.
But I can tell you for sure, if medicine, congenital heart surgery only.
I think I came to the conclusion that there isn't another profession in the world that is as that would make me equally happy.
I mean, this is really a terrific job. I think that it's been a terrific ride, without a doubt.
Find a job that you love and you don't have to work anymore.
For me, this sense of duty, this awareness of responsibility, and as you've seen, the sheer pleasure of doing the job means that they all would choose to do it again, despite everything. They must have something around it. The new generation that I interviewed as well are just as committed, but they're more thoughtful and considered, I think, than we were. I feel very honored to have trained with and trained many of these surgeons that you've seen tonight, to have worked with some others, and to have shared clinical and research ambitions and good times with them. I'm really grateful to them for allowing me to do these interviews, but I feel that I can reassure you that the hearts of children remain in good hands. There needs to be a last word after a talk like this, and I thought I should give it to Alex.
Why is drowning the most common cause of death amongst cardiac surgeons?
I don't know why is drowning the most common cause of death.
Because by the time they realise they can't actually walk on water, they still can't keep their mouths shut.
Thank you very much. Many people have contributed. My family, Becken, who helped me do the editing, my wife for rearranging quite a lot of this. To Nizar and Nagarjan at Great Ormond Street, who did so much work to put the films together with me. and the members of the UCHSA, the American Society for Cardiology and Cardiac Surgery, and the Latin American Society, and all of the individual interviewees that you've seen. Thank you very much, and I'm here if you have any questions.